Next, I would like to invite Suzanne Delbanco. She will be providing a presentation for you today. She is our keynote speaker. And Suzanne is the executive director from Catalyst for Payment Reform. She holds a PhD, excuse me, she holds a PhD in public policy from the Goldman School of Public Policy and a master's of public health from the School of Public Health at the University of California, Berkeley. Please join me in welcoming Suzanne Delbanco.
Good morning, everyone. I'm saying that with a lot of energy and enthusiasm to wake myself up because I'm on a different time zone than the rest of you, but I am really excited to be here, so it doesn't take a lot to energize me. This discussion is going to be so interesting today. When I first met Gloria, her energy was infectious. It was just really exciting to hear what she was thinking about here in Indiana, and I love that you're relatively new to this space. I think that's what gives you the gumption to look at things with really fresh eyes and think about how to do things differently, and I really love having company in that space. So thank you so much for the invitation to be here, and I am going to speak this morning about effective value-oriented strategies. And the title says payment strategies, but I'm actually going to be talking about a variety of strategies that dovetail with effective payment strategies, because the healthcare system is so complex that we have to think about how to attack it in myriad ways that complement each other and support each other. So that's what I'll be talking about today. But just so you know who I am and what perspective I'm speaking from, I just wanted to give you a little bit of an introduction to my organization. I'm the executive director of Catalyst for Payment Reform. And it's a funny name. We wanted to imply to everybody that we were trying to spark change in the healthcare system. But if it's too hard to remember, just remember that the healthcare system still does need CPR. So as you can see from the list of members that we have plenty of good company in thinking that the healthcare system needs change. We have pulled ourselves together to provide thought leadership to and coordination among employers and other healthcare purchasers who really want to get better value for their healthcare spending. And of course, as our name implies, payment reform is at the heart of what we do. But as soon as you start thinking about how to infuse value in the healthcare system, you realize you can't just think about the incentives you provide for healthcare providers. You also need to think about the incentives that consumers face, how they can navigate the system, how we can support a healthcare system and marketplace that work better. So we work on a variety of things, but I'm very proud of the membership that we have. We have actually some members in the audience here today, some who will be speaking, many large private employers, but also a growing number of state Medicaid, employee, and retiree agencies. We've got some union trust funds. We've got some universities. We even have a nonprofit in our organization. Most of them are large purchasers, but we even have some that are very small. But they all share a common mindset, which is that we have to do something differently as buyers of healthcare to send the signal about the value that we're looking for. And one of the basic principles that we have behind our operations is that you can change the healthcare system if you have a group of purchasers who come together in a critical mass, singing off the same page of the songbook, asking for the same thing at the same time. We can influence those very intractable players who are very fat and happy with the status quo and don't want to change, but if they hear from 5 influential customers about a change that they want to see, they are likely to be responsive. So that consistency of the ask, the coming together of purchasers around some common goals, these are all really critical. But at the same time, as we're pushing for change, we also feel it's critical to track our progress and hold ourselves and the healthcare system accountable for that progress. And the basic ways that CPR goes about its work, we're a 501c3 nonprofit organization, so our focus is on being an educational and charitable organization. We do a lot of education of purchasers. Many of our members are very sophisticated, but we're trying to expand the pool of purchasers who are activated and who want to create change in the healthcare system. We create plug-and-play tools. So how do you create a system where employers can all ask for the same thing at the same time? Standard questions to pose to health plans or mental health vendors or whoever are the players in the healthcare system. We create those tools, and by the way, if you're an employer and you register on our website, these tools are free to you. You don't have to be a member to use our tools because we want to create that big critical mass of purchasers who ask the same thing at the same time. And that coordination is just critical to what we do. And then research and analysis. We spend about 2/3 of our time helping employers and other purchasers become better purchasers and more effective by working together. But about 1/3 of our work is doing research, analysis, scorecards, report cards that shine a light on what is broken about the healthcare system and what we need to do to fix it. So with that as background on CPR, now you know who I am, where I'm coming from, and so you can take everything I say from that perspective. Let's talk about what are the key ingredients of a high-value healthcare system going forward. Now, I'm going to oversimplify here. We could talk, for the rest of the year about the aspects of the healthcare system that we'd like to change. But the 4 basic pillars that we think are critical are greater transparency, and I don't just mean for consumers who are shopping for healthcare. I mean greater insight into what is happening among the players and the dynamics in the healthcare system. Benefit design, so this is how a consumer interfaces with the healthcare system. What are the incentives or freedoms or restrictions that a consumer experiences? Provider network design, so this is looking at what access do consumers have to different providers and in what way, as well as payment reform, how we pay doctors and hospitals so that we can give them the right incentives and create the right environment for improving quality and efficiency and making healthcare more affordable. So these are the things I want to talk about. But I will say, as we are here in Indiana looking at Indiana results, and as RAND 2.0 and future studies will show these types of results in other states and other markets, you have to think about local market dynamics. Our country is so vast and so varied. Even within a state, you'll have markets that are very different from each other. And so there is no one-size-fits-all solution. When CPR got started, everyone was asking the question, so what's the solution? Is it bundled payment? Is it capitation? Should we move to capitation again? There is no one answer. It really depends on the dynamics among the healthcare purchasers, the employers and others that buy healthcare, the payers, the health plans or carriers or insurers, whatever you want to call that sector, the healthcare providers, and even the legal and regulatory environment will vary from place to place. All that needs to be taken into consideration when you think about solutions. So let's talk about payment reform. And just like me sharing with you where I'm coming from, I want to share with you how we at CPR define payment reform. So as I talk about it, you know what I'm speaking about. So for us, payment reform is a range of healthcare payment models that use payment to promote or leverage greater value for patients, purchasers, payers, and providers. Now, you would think as a group representing employers and other purchasers, we wouldn't care so much about those other sectors, but we really do, because we know for new models of payment to be sustainable, they have to be workable for all parties. So our definition of payment reform is broad for that reason. We also don't believe that something is payment reform if it isn't linked very seriously to quality. So if there's a new method of payment that isn't either reflective of a provider's quality performance or creating strong incentives for improved quality, we don't think of that as payment reform. It's just a change to the payment model. So what is payment reform other than that definition? In this country, as you know, traditionally, we have paid for healthcare using fee for service, a new payment for every unit of service that's delivered, sort of like our ordering a la carte off the menu and those individual prices. We still, as I will share with you, largely pay fee for service, even though we've had a huge amount of change. Underlying almost every payment model that's in existence right now is still a fee for service infrastructure. So when Gloria and the RAND folks talk about the importance of the Medicare fee schedule as a basis for potential payment reforms, it's not a crazy idea, because so much of payment and payment negotiation in this country is off of that Medicare base, whether it's the Medicare physician fee schedule or it's how hospitals are paid. That does serve as a basis. And so those individual fees, when we think about doing some kind of new payment like bundled payment or a shared savings model, we're just layering incentives on top of those base models or coming up with a budget based on what those amounts and relative amounts were for different services. So fee-for-service not only will continue to exist in a traditional manner in many places and for certain services, but it will also continue to be the foundation for many of the payment reforms that we are seeing in the marketplace today. And then as you move from left to right, payment models get more complex. They hold providers more responsible for spending and for their quality performance. So bundled payment, where you package a price together for a whole episode of care, whether it's a hip replacement or even caring for someone's diabetes for a year. That kind of package pricing for a certain episode of care is meant to help providers collaborate with each other, create greater efficiencies, hold providers accountable for the continuity and coordination of care. And those models have a variety of ways of being implemented. And then what we could call global payment or capitation, or something that looks at the total cost of care, is at the far end of the spectrum. And I think when the discussion around payment reform got started, the thought was we got to move from left to right. We got to move from fee-for-service all the way to global payment, and that's the path that we're on. But I think as people start thinking about local market dynamics, different services, some that are overvalued, some are undervalued, some where there's an adequate supply of providers, some where there's not an adequate supply of providers, we have to think differently in each circumstance about which payment method makes the most sense. And so realistically, we're going to be living with a whole variety. But could each of these methods be improved? Absolutely. And so that is what payment reform is all about. How can we take these ideas around how to pay providers, make sure that there's a component embedded in them that addresses quality of care and efficiency, and at the same time creates a good environment for providers to be able to operate and sustain in a comfortable way what they're doing, but also meets the needs of those who use and pay for healthcare. So ultimately, that is what payment reform is all about. So how much progress have we made? So when CPR got started in its current incarnation in the summer of 2010, and I took on the job as executive director, this was before we knew exactly what was going to happen as payment reform got rolled out for Medicare as a result of the Affordable Care Act. We did a quick informal survey of some of the biggest national health insurance companies and said, out of all the dollars you're paying to doctors and hospitals, what % are tied to performance in some way? And at that time, so almost 9 years ago, it was between 1 and 3%. So 97 to 99 cents on every dollar was paid to the healthcare system, regardless of the quality of care or the efficiency of care. Fast forward to where we are today, and CPR, as part of its research work, tracks this very carefully, both through user groups that we do nationally with some of the biggest payers, as well as behind the scenes for the Healthcare Payment Learning and Action Network, which is a offshoot of CMS, which is tracking the nation's progress on payment reform. And we know that we're now just above 50% of payments having some kind of quality component tied to them. So we've made a huge amount of progress in not that many years. In less than a decade, we've made a sea change in terms of the number and volume of incentives that are in the healthcare system that providers are facing. And these new payment methods are important because they're essential to supporting new delivery models. So if we want to see patient-centered medical homes succeed or accountable care organizations succeed, they can't be tried without new underlying payment models that create the possibility for providers to reorganize around these new models of care. But as we have made so much progress, we still have so much more to make. The vast majority, over 90% of these payments, probably over 95% of these payments, still have a fee-for-service chassis. So we're layering incentives on top, but that fee-for-service is still there. So all the perverse incentives for more volume are still underlying, and really what we're trying to do is counteract those by adding some other incentives in the right direction. So the fee schedule that underlies all that is really important. So if we're not paying providers for something essential like coordination of care or email correspondence, but we're paying too much for other things that are really not of great value to patients, all of those incentives carry forward with these new methods of payment. So we really have to think about what the fee schedule is that underlies things. We also need to really pay attention to evaluating new programs, new models, because it's great to say we have so much payment reform happening, but it's only an intellectual exercise if it doesn't lead us to higher quality and more affordable care. And I don't think we can say in this room yet that we've gotten there. So evaluation, continuous, rigorous evaluation is absolutely critical. And it's boring to talk about, but it's so important. The other thing I would say is that we have to make sure that we align the incentives correctly. So if we're giving incentives to providers, we need to make sure that the patients have incentives that are aligned. So if a provider is being held responsible in any of these payment models, let's say for keeping someone's diabetes under control, but yet the patient has a high deductible plan, and so they hesitate to buy new test strips when they run out, or they hesitate to go to the provider for their yearly eye exam or foot exam, then we have a clash. We're putting doctors and hospitals against patients not lining up the incentives correctly. So we have done a lot of thinking at CPR and have published a whole volume of papers with the Urban Institute about how to line up provider payments with benefit designs and provider network designs so that people can do that thoughtfully. Usually we think about these things in silos. So going back to the idea of evaluation, I wish we could say now that we have over 50% of payments tied to quality somehow that we're far better off. We're still in an era of intense experimentation. Many people have drunk the Kool-Aid of ACOs, for example, but if you look at the data, the results are frankly quite mixed. Some people say it's because most models are only supported by shared savings, so there's only an upside for providers. They don't feel the pressure so much to really improve. We need to get to shared risk where there's a downside in terms of how we pay for them. But we don't really know the answer yet because there hasn't been that much experience. Some of Medicare's early forays, they actually lost money on the accountable care models because it cost them more to administer the program than they were able to save. But there are other examples of where ACOs are starting to make strides, but it's early days yet. But we can't say that it's a slam dunk. Same thing for bundled payment, although I would say that the evidence tilts more toward the effective nature of bundled payments. But again, it depends on how the model's designed. The details really matter. In some cases, bundled payments have had huge impacts on quality. The example of Pacific Business Group on Health here saving money on labor and delivery services because of a reduction in cesarean delivery. But other examples where it hasn't panned out quite as well. At the end of the day, bundled payments are promising, but again, if we don't study what makes them work and in what context, we're not going to be able to make as much progress as we need to. In addition to some of those examples, one of our members, the Pennsylvania Employee Benefit Trust Fund, implemented a bundled payment program for hip and knee replacement. They found that the program did very well at reducing outpatient costs, on average $3,500, but inpatient costs remain the same. So there's pluses and minuses to all these programs and how they get implemented, and there's a lot of tweaking and iteration that we need to do. And of course, bundled payment, which people get very excited about, is still volume driven. If you come up with a great model of producing better quality and a better price, the provider still could do more bundles, even ones that aren't necessary. So we have to be careful everywhere we go. You add some incentives into the system. There's also perverse incentives that sometimes come with them. So there's been a lot of evaluation, but not enough of these individual programs that I was just describing. And one of the things that occurred to us at CPR is that if we just keep looking at one program at a time, we're not really seeing the whole forest. We're just looking at the trees. And the healthcare system, as you all know, because you're part of it, is remarkably adaptive. So if a provider or payer does really well in a particular program, they're proud of it and they highlight it and everyone's excited, the question is, did something else get neglected? Did something else have a price increase? Did something else happen in terms of increasing the volume of services where it wasn't necessary? And so we felt that it was important to go up to about a 50,000-foot view and look at the forest to see if all these sweeping changes to payment were having the right impact on the healthcare system. So going backwards in time again, when CPR got started and said we want to see more payment reform, we set a goal for ourselves of 20% of payment being value-oriented by the year 2020, which is just next year now. And so to hold ourselves accountable and hold the healthcare system accountable, we started creating national scorecards, and actually regional scorecards, so state and national scorecards. And in 2013, when we performed our first one, we had gotten up to 11%. By 2014, our next national one, we'd gotten up to 40%. Then we started looking at New York, California. We actually did one on the Medicare program before it started tracking itself. And all of these were showing us an increase in payment reform. But what we didn't know is what impact it was having, and that was very frustrating. So fast forward to a few years ago, we were lucky enough to get funding from the Robert Wood Johnson Foundation and the Laura and John Arnold Foundation to help us create what we call Scorecard 2.0. The goal was to help us not just see how much payment reform there was and what types, but also what impact it was having on the healthcare system in terms of quality, efficiency, affordability, and those kind of matters that really help us gauge whether or not this payment reform movement is succeeding. So we looked at creating metrics with the help of a national advisory committee that would help us understand what are the economic signals in the marketplace, how is that leading to system transformation in terms of the delivery of care, and how is that impacting the outcomes that patients experience. So at a very macro level, we were setting about creating a whole new type of scorecard. And we put out a request for proposals to states and got interest from 13 states in creating these scorecards. It shows you the kind of interest there will be in the studies that we're going to be talking about here today that Rand has done. And through a selection process, we decided to work with Colorado, New Jersey, and Virginia. And you can see the organizations that led the sponsorship of our efforts at the state level. So just as an example, I'm not going to walk through the details here to show you what our scorecards look like. What we found was that, yes, we had made more progress in the number of payments and the dollars flowing through payments that had a link to quality. And they varied tremendously, by the way, across these 3 states. And in each state, we did a scorecard for both the commercial market as well as the Medicaid sector. And so there was variation all around. But at the end of the day, we're seeing progress in terms of the number of value-oriented payments being made. And slight increases in the amount of risk, financial risk we're placing on providers, creating stronger incentives for quality improvement and affordability. But what we really were excited about is this whole new section of the scorecard that looked at the impact on the healthcare system. So we have measures looking at the types of provider networks that are out there, especially limited networks. We're looking at system transformation in terms of how many C-sections are happening. How are we doing with HbA1c testing? How do people feel about the quality of their life related to health care? How many people said that they had unmet care due to the cost, so they deferred getting care because it was too expensive? How many shared risk contracts are out there? So how are we doing in terms of the process of care? And then in terms of outcomes, we have some metrics getting at things like how well are people's blood sugars controlled, how well are we doing at childhood immunizations, and instructions for how to recover at home after a hospitalization. As you can see, some of these you could move between the system transformation and outcomes. There's sort of a continuum of metrics here. But the bottom line is we've created a benchmark. So now these states that have done these scorecards for the first time can start tracking year over year how payment methods change, and do these outcomes measures for the healthcare system get better? We would hope that they do. And we're actually very excited to be embarking on a retrospective study now, looking at our initial scorecards in 2013 and 2014, populating these same metrics, and then we're going to carry them forward to the present day to see, with all these changes in healthcare payment, how are we doing? And I just raise this not as a way to advertise the work that CPR does, but to say we have to really scrutinize every individual program as well as the impact at the macro level. Because if we don't do that, we're going to miss how adapted this healthcare system can be and fool ourselves into thinking that we're better off when we aren't. When I talked at the beginning about transparency being critical, it's critical at every level. We have to have these kinds of insights into how the healthcare system is performing. And another example of how we've tried to do that is with the big ACO movement afoot, and many health plans being very excited about the ACO movement. Our employers, our members, were very frustrated at the lack of transparency that they were getting from their contracted health plans about how their ACOs were performing. We were getting just a few measures reported to us each time. They were always positive. We never heard really the full story. So we worked with a group of our members to create a standard ACO plan report that's inspired by the nutrition label. So, when you look at a soup can, all those cells have to be filled in. They can't skip telling you how much sodium there is if they want to. So we created a template that we've given to health plans now and asked them to report to us, so we really have the full story of what's happening with ACOs. So evaluation is important, transparency is important into the performance of the healthcare system. But at the end of the day, going back to the theme of this conference, prices really matter too. We can't forget the prices, especially because when you look forward to what economists are saying is going to drive healthcare cost growth the most, it's prices. This is something that's negotiated. This is something that is changeable. This is not the demographics of the healthcare system or the coming technologies that are going to make us better off but bankrupt us. This is about a negotiated price. And so why does price matter so much? Why does Indiana get to charge so much more than Medicare? It has to do with those market dynamics I talked about at the beginning. Provider consolidation has been happening at a rapid clip over the last decade. I'm sure all of you can name some healthcare systems that have merged, acquired, even across state lines. All of this has evidence about a mile high for its impact on price. We know that consolidation rises price. I don't want to hear again a health system CEO promise about the economies of scale and the efficiencies that are going to come with a new merger. The evidence just doesn't bear it out, I'm sorry. So consolidation is going to continue. We know it is. And we also know, as Gloria said, that prices have no correlation to quality. It'd be one thing to pay a higher price so you were guaranteed a better outcome. That is just not the way it is in this country right now. There is no correlation whatsoever. And in fact, we've had to educate people a lot, consumers, that paying more in healthcare does not necessarily mean better outcomes. So all the reforms in the world, all the payment reforms in the world, getting better effects from bundled payment could be completely negated by higher prices continuing to rise. That didn't make sense, by prices continuing to rise. So even if you have, maybe you'll have better quality at least for the higher price, but in terms of better affordability, it's going to be completely overrun by prices being higher. So what's exciting is that we're starting to see states taking action. And I know you'll hear today about Montana, which is great. I don't think we have anyone from North Carolina here today, but people are starting to think the same way Gloria is, or actually have already thought this way, about how looking at the Medicare payment amounts as a base could be a first step for thinking about new ways of setting prices so that they are not so out of control. And the exciting thing about state purchasers, and some of our members are these state employee or retiree agencies, is they've got volume. And they have a lot of leverage in the system. And especially when they lead the way, there are going to be a lot of purchasers in the commercial market who are going to be excited about following suit. So not to scare anybody, but I think that this trend might be just at the beginning. So I want to make sure I'm doing okay on time. I think there's a few minutes left. So I just want to talk a little bit about what's happening in these other spaces. So we've talked about payment reform, we've talked about prices. Now let me just talk about the other complementary areas that matter: benefit designs, provider network designs, et cetera. So in addition to all this attention to changing the incentives we have for providers, there's been a lot of innovation and experimentation, especially in the last 5 years even, around new health insurance benefit designs, those incentives that face consumers. What we're seeing is that employers are starting to recognize that all healthcare is not equally important or effective, and some healthcare is incredibly critical for patients, and we need to think about that spectrum as we design benefits. So a recent survey by Willis Towers Watson, which does an annual survey of employers each year, found that 26% of employers were reducing out-of-pocket costs for the use of high-value services. So going back to that example of someone with diabetes, if you waive the cost for the care that they need to keep their condition under control, people don't then have a financial barrier to getting that care. But what's interesting, I thought, was that 43% of employers are also increasing out-of-pocket costs for services that are overused. I think that's a relatively new trend, and I was surprised to see that number was so high. The other trend that I'm seeing a lot among our members is the use of second opinions, expert opinions that a patient will get in addition to their primary diagnosis to make sure that the diagnosis is correct before they proceed with care. A couple examples of how these innovative benefit designs are working. We just released a case study not long ago on Walmart's Center of Excellence program on for spine surgery. And when they created a benefit design that waived the cost for patients going to the Center of Excellence, they found that 50% of them who had been referred for spine surgery were then told that that was not the most beneficial path for them to follow in terms of addressing their low back pain. 50%. So Walmart hadn't even bothered really trying to negotiate for a lower price from the Center of Excellence. Where the savings is coming from is more appropriate care. And that benefit design has been really critical to getting people to true experts to diagnose not only their condition, but also the best path of treatment. Similarly, you'll hear from Kathy Donison later about all kinds of things, and she's just an amazing wealth of information because CalPERS is such a leading purchaser and has tried so many things. In the early days of CPR, we were very excited by what CalPERS and Safeway were doing around reference pricing, and in fact, really sparked our work on price transparency and the need for price transparency, because if you don't have that, you can't then help consumers shop based on price. And CalPERS looked at hip replacements and knee replacements across the state of California and found they were paying a hugely, widely varying amount of money, tens of thousands of dollars difference from one hospital to the next. And they set a price that they felt would guarantee enough access for their members, but also really lop off the excess cost they were paying to overpriced providers. And they found that as a result of the program, they were able to reduce the average price by 26% and reduce the selection of high-cost providers by 34%. So then, related to that, provider network design. I'm sure you've been hearing a lot about limited networks, tiered networks, narrow networks. People use a lot of different terms for these things. But these data are a little bit out of date. I looked for some more recent ones, and any minute now there'll be the new survey coming out. But in 2017, 13% of providers were of employers were offering high-performance provider networks. 31% were offering Center of Excellence programs like the one I described by Walmart. And 22% of employers had on-site or near-site clinics. And these play an interesting role in helping not only enhance primary care and access to care, but helping to control utilization of the healthcare system out there and the community providers, including making smart referrals to those who are higher value. So do these network designs work? We think of Americans as wanting all the choice in the world, but in fact, we're at a pivot point. Healthcare has become so unaffordable that people are willing to have some restrictions on their choice in return for health insurance that they can afford. And not only do consumers have a willingness now to use these plans, but they are effective in reducing costs. One study of a large payer that was not named in an academic peer-reviewed journal in the southeastern U.S. had lower mean outpatient out-of-pocket expenditures and a 10% lower premium than individuals who had chosen a broad network plan. So that's a 10% reduction, which is quite significant. The Group Insurance Commission in Massachusetts, which buys for state employees and retirees, was an early pioneer in trying out tiered networks and narrow networks, and they found that enrollees in narrow networks spent 36% less. They also found that their tiered networks meant that poor performing providers had a drop of 12% in their market share in terms of patients. Blue Cross Blue Shield of Massachusetts did a tiered network and found that it reduced the total adjusted medical spending per member per quarter by 5%. These are all pretty significant figures, and I think we're going to see studies of these types of programs continue to come out. And like I said, Americans are willing to make trade-offs for now. We have actually seen among our members much higher than anticipated enrollment in some of these offerings. I give as an example here a case study that we just released today of Qualcomm and its ACO program in San Diego. They were expecting a certain amount of enrollment, and what they got far exceeded their expectation because the price was so attractive and because they chose to partner with a very high-quality provider. So I would say that Americans are willing to make trade-offs for now, but what's critical is that we not only have them do it on price, but also on quality. We need to bring quality into the equation when tiered networks and narrow networks are formed and formulated so that they can rest assured that they're not trading off quality for price. So what can we do going forward? We have to push more and more for continued price and quality transparency. In order to identify value, we can't do it if we don't have that information. We need to see more experimentation and the use of new benefit designs. These are critical not only for consumers, but also for the providers who are trying new payment models and need to make sure that their patients have aligned incentives. Provider network designs, I think, are going to be a hot ticket going forward. Other than trying to impact price, if you can lop off the 10% most expensive providers or those really poor performers in terms of quality, and even just have a narrower network, there's a lot of savings and quality improvement to be had very quickly. And so I think as employers watch each other and see that these programs are succeeding, we're going to see more of them. And of course, I believe we need to continue with alternative payment models. Payment reform is happening apace, but we need to keep making sure the incentives are strong enough, moving towards shared risk, and evaluating programs so we understand what works in what context. We also need to encourage new entrants into the marketplace. All that consolidation I talked about among providers means there's less and less competition, and that has a direct impact on price. So it's very exciting to see the use of telehealth, on-site and near-site clinics, retail clinics, urgent care centers. All of these things are creating competition and providing alternative sources of better value care for consumers. And then, of course, we're going to talk more today about effective strategies around pricing using Medicare as a reference price. So with that, I'll stop, and I don't know if there's time for questions. Okay, so I'm happy to answer any questions. Looks like there's a microphone that people could ask questions at. Yeah. When you ask a question, please state your name and organization so everyone knows who you are. There's no way I answered everything.
Suzanne, that was a great presentation. I'm Cheryl DeMars with the Alliance in Wisconsin. So you talked about consolidation's going to continue, prices are going to continue to go up. I don't disagree with that, but it made me wonder if there's a role for some governmental intervention around antitrust.
Yeah, it's a great question. So I could talk about this all day. It's one of my favorite topics, but I won't. I think that we at CPR about 6 years ago, we held a national conference on the impact on provider market power. And we tried to raise the alarm, help employers understand what was happening. And then we spent the next several years focusing on innovative benefit designs, network designs, price transparency, all the things that we thought we needed to infuse into the system to create enough competition. But when we continue to see the evidence mounting as it is, I question whether or not market forces alone are going to be able to address what's happening to price. And I think there's a lot we can still do in the marketplace. And if we see efforts like Gloria's succeed and purchasers find some way to pool their volume at the local level to insist on change, that might work. But very few organizations are like the Alliance that have succeeded really in pulling purchasers together and sticking together for a long time. So I think there's always a potential role for policy intervention. And we're actually having a series of webinars in April looking at these very issues. And we actually have been working with UC Hastings, which is a law school in San Francisco, to create a database of laws across every state that have tried to address issues related to healthcare value. So it'll be a great resource. Other questions? Well, I'll be here all day. I'm happy to answer any others that come up. Thank you so much, everyone.